Hey everyone, it's Alisa, and I have another step 2 question for you. Go ahead and pause this, answer it yourself, and come back with me and we'll work through this together. A 47-year-old man comes to the physician for a routine health maintenance exam. He was diagnosed with HIV 16 years ago. He was taking triple antiretroviral therapy but stopped a few months ago because he was feeling fine. He lives in Mississippi. Vital signs and physical exam are normal. His CD4 count is 47. The patient refuses to restart his therapy. Which of the following medication regimens is most appropriate at this time? Now, you will see a lot of questions about, what kind of prophylactic medications to give HIV patients, and it's very important that you know these. So, I thought it would be useful to review what kind of opportunistic infections HIV patients are susceptible to based on their CD4 count. So, at a CD4 count of less than 500, and 500 is normal, the patient is susceptible to Candida, and they're usually going to get an oral thrush, which is a scrapable white, film on the tongue. And then you see pseudohyphae on microscopy to diagnose that. You can also get EBV oral hairy leukoplakia, which is non-scrapable in comparison to Candida. They can get HHV8 Kaposi sarcoma, which is a palpable lesion that's brown, pink, red, anything. And they can also get HPV, for example, squamous cell carcinoma of the anus or cervix. Now, on a CD4 count of under 200, they become susceptible to histoplasma capsulatum, which presents with not very nonspecific systemic kind of findings, such as fevers, night sweats, chills, weight loss, dyspnea, nausea, vomiting, and then the macrophages contain oval yeast cells, and that's classically like the pathognomonic thing you should know. They can also have JC virus reactivation, which causes PML, a demyelinating disease of the CNS. They can get PCP, which is a pneumonia with ground glass opacities on chest radiography. And to prevent that, and this is the first one that we see that we can give something to prevent because it's actually quite common and easy to become afflicted with for HIV patients, you give trimethoprim, sulfamethoxazole. And if that's contraindicated, you can give Dapsone, atovaquone, or pentamidine. And then the other thing that these patients can get is cryptosporidium parvum, which causes watery diarrhea, and we can prevent that with nitazoxanide. Now, with a CD4 count of under 100, you start to see bugs like aspergillus, which causes hemoptysis, pleuritic chest pain, and a variety of other things. Bartonella henselae, causing bacillary angiomatosis, comes into play. And now Candida can cause something like esophagitis, which is a lot more severe and needs systemic therapy, unlike oral candidiasis. CMV, which is extremely dangerous, which causes retinitis, esophagitis, colitis, pneumonitis, anything you can think of, and causes linear ulcers on endoscopy. Fundoscopy, you might see cotton wool spots. That's good to remember. And then classic, you see intranuclear inclusion bodies, OI inclusion bodies. That's a buzzword for CMV. And the treatment is glencyclovir. Now, again, cryptosporidium comes up, EBV comes up, causing B-cell lymphoma. And then here's the most important one, MAC. Causes nonspecific findings, fever, night sweats, weight loss, lymphadenitis. And we need to prevent MAC because it's fatal a lot of the time. So we prevent it with azithromycin. So far, we have two preventatives. We have azithromycin for MAC, as well as TMP sulfamethoxazole for PCP. So keep these in mind. Now, the last one is Toxoplasma gondii, which causes ring-enhancing brain abscesses, classically ring-enhancing lesions. And we prevent and treat it with trimethoprim sulfamethoxazole, which is very convenient. And again, if that's contraindicated, you can give these drugs. But if you have ring-enhancing lesions, we give something else. Great. So we keep these in mind. So what you really need to think about is what's the patient's CD4 count? What bugs are they susceptible to, and how do we treat those bugs? So again, this patient's CD4 count is less than 50, right? So he's susceptible to pretty much everything and anything. So let's go back to our answer choices one more time. So we have azithromycin, Trimethoprim and sulfamethoxazole, Amphotericin B, Dapsone, and then combinations. So note that we did not talk about Amphotericin B as a preventative medication. So let's go through our answer choices. First one is Azithromycin, which is a great choice for prophylaxis against MAC, but you got to think about PCP and toxo. Now, just trimethoprim and sulfamethoxazole are great. However, it only covers PCP as well as toxoplasmosis. However, we still haven't covered MAC. We need azithromycin. Now, amphotericin B. Systemic candidiasis is a pretty terrible thing. However, amphotericin B has so many side effects that we do not give it prophylactically. And that's such a big gun kind of drug that we do not want to develop resistance. So we typically do not give this unless someone is afflicted with a fungal condition. Dapsone are alternative drugs for PCP pneumonia, but again, we're looking for other things to cover. And finally, TMP, sulfa, azithromycin. This is what we're looking for. We need this to cover MEC, PCP, and toxo. So this is a great choice. And then our last option is all of those above plus an amphotericin B. However, as we mentioned, we don't give amphotericin B because of resistance and because of severe adverse reactions. So our answer is E, trimethoprim, sulfamethoxazole, and azithromycin to cover MAC, PCP, and toxo. This is started when patients have a CD4 count of under 200 and continued essentially until their CD4 count improves. So for this patient, we want to start him on his antiretroviral therapy and continue taking these medications until for 3 months he can demonstrate that he has a CD4 count of above 200. And then these medications can be discontinued while he continues his antiretroviral therapy. All right, I hope you enjoyed this question, and we'll see you next week.